So visceral pain. How might the viscera experience pain themselves? So we know that the visceral afferents communicate to the autonomic nervous system via the sympathetic and parasympathetic nervous system. The specific branch of this nervous system that has to do with the GI is called the enteric nervous system. And that part of the nervous system has as many nerve cells as a human spinal cord. So there's a lot of communication in terms of what's going on in the gut. But there's few nociceptors. So a lot in terms of regulation, secretion, of things, digestion, all of that, but not in terms of pain signals. There's few nociceptors found in the viscera. All right? Therefore, pain is diffused and poorly localized. The brain doesn't recognize it very well. This is just to reflect back to that wonderful chart you remember from school, maybe. The gas pedal and the brake, as I like to think of it, the parasympathetic and the sympathetic, and the specific part that relates to the gut is the enteric nervous system. And part of the parasympathetic nervous system, we have the vagus nerve. So I remember learning it's cranial nerve 10, right? There's so much more it does than that. When we really look at it, it wraps around the esophagus and it innervates all the abdominal contents with the exception of the adrenals and the lower half of the colon and the pelvic contents. Those are the pelvic nerves. And the adrenals are innervated by the phrenic nerve. But the vagus nerve has a lot of influence in the entire gut. And you're really looking at all of the different little branches are called plexi and ganglia that help regulate what's going on. So how might the viscera experience pain when they do have pain? Since there's few nociceptors, it might happen because of mechanical pain. And that's that idea of you ate something bad, you're super bloated now, and you know there's discomfort there. But what's always amazing to me is you're super bloated and uncomfortable, but you can't always quite pinpoint where. It's just this generalized discomfort. But that pressure is mechanical pain. Inflammatory pain is when something has caused inflammation, you have the inflammatory mediators present, and they start to hypersensitize the nerves, and you start to experience more pain because those mediators are present. Ischemic pain happens with the release of metabolites when there's a lack of blood supply. So that's like angina type pain. So you have something, you have a torque in the volvulus and the intestine loops, they're cut off, like with a hernia, and the blood flow starts to get cut off, metabolites build up, and now you're having ischemic pain. And then referred pain is the one I'm going to be going into a lot more, and this is how the viscera refer to the musculoskeletal system, away from the site where the actual problem is. How might it present? So the big thing on this slide that I want you to think about is it's not activity dependent. So it's not like a shoulder injury where when I reach up it hurts, if I put my arm down it feels better. Visceral pain, I reach up it might feel better, I reach down it might hurt. It's not activity dependent. They'll say, I haven't really found anything that provokes it or alleviates it. It's just kind of random. It may be constant, maybe wave-like, it may come and go, but it's not activity dependent. The other big thing is position doesn't change it. The exception of that is that fetal position may feel somewhat better, but it doesn't make the pain go away. Okay? So position doesn't change it, it's not activity dependent, and then the big one that I look for is eating changes my symptoms, either making them better or worse. But if they say my pain, my symptoms are different when I eat, that's a little kind of signal in my head that goes, something else is going on. It's not just musculoskeletal. The other big one is, or bowel movements change my symptoms, whether it's better or worse. Most commonly, eating makes it worse, bowel movements relieve. That's classic signs of IBS and other things like that. But it doesn't mean it will follow that pattern. It's just if it changes with eating, start thinking something else. Your classic red flags, these you know, but just to point out, if I'm having a patient and treating them, if they have classic red flags, I'm referring them back as appropriate. Okay? I like to make sure they've had their imaging, they've had their CT scans, their blood work, everything's been ruled out. It's nothing, it's not a tumor, a mass, or anything majorly concerning, that now, even though there are some viscerogenic pain symptoms present, I need to delve in why, how might structures be stuck that's creating this problem, and not something more critical that might fall under this. So that leads into contraindications, precautions. This is not absolute, this is not all-inclusive, but this is just a list to start to have you have some ideas of if there's active infection, if there's active inflammation, I'm not treating them. If they have a tumor or a mass, They have a hematoma, or thrombosis, excuse me, not hematoma, thrombosis or bleeding ulcer, an aneurysm, I'm not treating them. Okay? Hemorrhage or fracture, that fracture can fall under precautions because it depends on where it's healing, but if it's an acute fracture, not treating. And then if you do get them and you go to put your hands on them and they're just in excruciating severe pain, they're screaming and crying, send them back. Precautions, on the other hand, of when do we apply this visceral manipulation in children? Okay? So with infants, there are a lot of precautions, and there are some techniques that can be applied, but they're very specific techniques, and usually they recommend that you've had a lot of experience with pediatric population before you're treating infants. The other sort of precaution is, as long as they are crawling, you can start applying the more direct 3D tension techniques. If they're not crawling, if they're at least rolling, there are some direct, indirect, those into ease and other techniques that can be applied. So we're looking at some stages of development of knowing when they need to be applied or not. But the direct tension techniques, they want those structures integrated with crawling so that they have some appropriate forces already applied into the body, and the body's learning how those structures need to be aligned before we're starting to manipulate them. Post-surgery, it's recommended waiting 6 weeks. There are some things changing with this, but this is the current precaution that I still go by now. After radiation or chemotherapy, obviously you don't want to be stretching or moving irradiated tissue, so use precaution with that. And then foreign body, mesh, feeding tube, trach. If they have a trach or a feeding tube or something, you're not working directly on that. You're working maybe away from the site. You don't want to be moving something that's been implanted. You don't want to be dislodging anything. And then edema. So if you're seeing somebody and doing lymphedema, that's a different case. But if they have an active edema present, you're not going to be working through that. So how does this referral of visceral pain happen to the musculoskeletal system? Well, we're learning more about it. Research is being done on it, but it's not well understood. There are 3 main theories in place: embryologic development, multi-segmental innervation, and direct pressure and shared pathways. So I'm going to go into these because that just sounds like a lot of, what is all that? So in terms of embryologic development, this is the idea that any structures that during development were in contact with each other, as they migrate out and find their final location, they can still refer to each other if they were touching during development. So an example of this would be, a lot of times pneumonia can be felt as gut pain because those two were in contact with each other during development. So that's one theory. The other is multi-segmental innervation. So this is the idea with that sympathetic chain. So let me go to that slide so you have it. That sympathetic chain, the anterior sympathetic chain, all the information that's coming in from the viscera is coming in at the same levels as nerves from the musculoskeletal system, our dermatomes. So anything that comes in can get confused as it conjoins and goes to the brain. So the brain can't always tell. It's that same idea of how pericardial refers to that left arm. Is that it's getting confused as it comes in, and the brain says, well, usually it's the musculoskeletal system that's injured, so it blames that first, as opposed to a visceral structure. Direct pressure and the shared pathway. Direct pressure, we're looking at anything that comes in contact with the diaphragm. So we think back to the diaphragm. The diaphragm has the lungs above it. It has the heart. It has below it the liver. And then we have the stomach, and the spleen, and the pancreas, and the kidneys and adrenals come up above. So anything that's coming in contact with the diaphragm can start to influence the diaphragm because of the phrenic nerve. And again, it's back to that C3 through 5. So input coming into the phrenic nerve can be miscommunicated because it's coming in C3 through 5. Well, what else comes off C3 through 5? We have dorsal scapular nerve, suprascapular nerve, axillary nerve. So everything that kind of goes to that quadrant shoulder can start being miscommunicated with the brain from the visceral structures. And the phrenic nerve innervates pericardia, the lungs, the diaphragm, part of the liver, part of the gallbladder, directly, the pleura of the lungs, and the upper portion of the peritoneum. Now, if we think back to the peritoneum, we said that's one continuous sheath. There's a pressure system in there, so anything really within the peritoneum that puts pressure into that upper peritoneal portion, those the anchoring of the colon, so the transverse colon anchors into the hepatic flexure and the splenic flexure. So anything in there can refer up to the diaphragm. What if I'm being pulled down below, like from an appendix scar? So really anything that comes and creates an influence into the diaphragm then can refer into those upper quadrants. So it can get very complicated to the brain because of all these shared pathways, because of all this compression, because of the miscommunication, and the organs don't have clear nerve endings like our hands do. The brain doesn't know where it's coming from. And I love this slide because you start to look at it and you go, oh my gosh, it's that 80s, all the cables behind the TV, and you go, oh my gosh, it's all tangled, I don't know what cord goes to where. Times like 100. All the plexi, all the ganglia, all the input that's coming in, and our brain has to interpret where that information is coming from. And it gets miscommunicated. The next few slides are really for references for you, but if we start to look at, okay, what are these patterns looking like? There are some patterns. The esophagus tends to refer to the mid-thoracic and neck. The liver, diaphragm, and pericardium to the upper quadrant. Okay, ipsilaterally usually, but not always. Because of those ganglia and plexi, the gallbladder can refer to the left shoulder because they're little like roundabouts, and sometimes it goes up the left side and sometimes it goes up the right side to the brain, and it can't quite tell where it's coming from. The gallbladder, stomach, pancreas, and upper portion of the small intestines tends to refer to that mid-back, scapular region, epigastric region, and upper quadrant. And then if we get to the lower portion of the small intestines and colon and pelvic, you start getting that referral into the low back, pelvis, and hips. So this is a nice sort of, if you can remember this, you start to have a better idea of, oh, they have hip pain, it could be these structures. Oh, they have right shoulder pain, maybe it's these structures. So you start to get an idea of what refers where. You want to have extra cheat sheet, they're coming up. So this is just unfortunately I couldn't find one on a pediatric, on a child, so this is an adult version. They should be fairly similar, but again, we're looking at the kidneys have this huge referral pattern to the low back and hips, pericardia, liver, lungs, diaphragm. I find that they're not that isolated as this picture. They could be more diffuse, and so I find that really these slides are more informative. So if we want to pick one, for example, the gallbladder comes off of T7 through T9 in terms of sympathetic chain, and where it might refer. It tends to refer to that right upper abdomen, right mid, and lower thoracic spine. But again, because of the celiac plexus and some of the other plexi that innervate and come in and communicate with the phrenic nerve, communication can kind of get right-left confused. So there's one for the lower GI. So here we're looking at jejunal ileum, or ascending colon, or descending, or sigmoid, and the regions that they may tend to refer to. Cecum's on the right, it tends to go to the right hip. Sigmoid's on the left, tends to go to the left hip. Urogenital organs, kidneys, have a pretty large area that they can refer to. Ureters, bladder, ovaries, prostate, this kind of breaks it down a little bit more of what segments they come off of and where they refer to. So, now I'm going to introduce Dr. Erin Appelt. She is a full-time faculty at Midwestern University and assistant professor, and an honor to be here with me this morning. I really, really appreciate it. She is going to talk to you about the research.